We move on to the next topic, and for that I would like to invite the chairpersons, Dr. Kashinath Dikshit, who is the consultant physician and diabetologist at Krupa Diabetes Center, Bengaluru, and Dr. Sahadev HK, consultant physician and diabetologist at Holy Cross Hospital, Chikmagalur, also the EC member for API Karnataka. We welcome you on stage, doctors.
Good morning, everybody. Thanks to good friend NSM for providing us this opportunity. We have a very interesting topic by Dr. Anil Kumar Virmani. He's a consultant physician, cardiologist, diabetologist. More than that, he's a cyber crime intervention officer. Cyber crime intervention officer. And he is a council member of Indian College of Artificial Intelligence in Medicine. And he has got a lot of achievements. Without wasting much time, I request Dr. Anil Kumar, and his topic is
Pharmacological interventions to mitigate insulin resistance.
Good morning to all of you, and honorable chairpersons, respected seniors, and dear friends. The topic that I will be talking about today is what are the pharmacological interventions to mitigate insulin resistance. No disclosures. Just to give you a slight introduction, almost 82% of the Indian type 2 diabetes suffer from insulin resistance, and it's because of the Asian phenotype, and insulin resistance is a root cause of all the problems, metabolic problems that we face. Now, what is the clinical significance of insulin resistance? It is defined as a state of reduced responsiveness of insulin targeting tissues to physiological levels of insulin. Earlier, once upon a time when we were in college, we had read more than 200 units, but that is no longer there. It is the physiological levels. That is important. And obesity, one of the most common causes of insulin resistance, is associated with a decreased number of insulin receptors and with post-receptor failure to activate tyrosine kinase. Insulin resistance is associated with multiple conditions: hyperinsulinemia, type 2 diabetes, impaired glucose tolerance, central obesity, hypertension, dyslipidemia, the classical atherogenic dyslipidemia, hypercoagulability, metabolic syndrome, MASLD, polycystic ovarian syndrome. And endothelial dysfunction is a prominent feature of the insulin resistance syndrome, and that is what contributes to cardiovascular disease. The major tissues involved in insulin resistance are the liver, muscle, and adipose. So before I go to the insulin sensitizers, it's important to understand what is the mechanism of insulin. Now, this is the condition I already talked about. We know the signs of insulin resistance clinically. There is skin tags, acanthosis nigricans, weight changes, etc. Now, it is very important to understand the role of insulin signaling. When we look at the skeletal muscle, if you look at that skeletal muscle, the insulin binds to insulin receptor tyrosine kinase, and that is a chain of reaction. The ultimate aim is to promote glucose uptake via the translocation of glucose storage. In the liver, AKT decreases gluconeogenesis, increases hepatic glycogen synthesis, and increases hepatic de novo lipogenesis. And in the adipose tissue, that is the white adipocyte, insulin suppresses lipolysis, and this in turn suppresses hepatic glucose. and this promotes glucose transport, lipogenesis, and adipogenesis. So what are the pathophysiology? There are defects in insulin receptor signaling, ectopic lipid accumulation in the liver and skeletal muscle leading to lipotoxicity, endoplasmic reticulum stress, low-grade chronic inflammation, and mitochondrial dysfunction. And the key molecular pathways that are involved are the IRSP13K-AKT pathway, AMPK activation, PPR gamma signaling, and cytokine-mediated insulin resistance. It is also important to understand the mechanism of insulin resistance, the glucose fatty acid cycle, that is so-called the Randall cycle hypothesis. And what happens basically is that there is an increased fatty acid oxidation, limited insulin-stimulated glucose utilization, and lipid-induced insulin resistance in skeletal muscles. There is an increase in the mitochondrial acetyl coenzyme A levels. This inactivates pyruvate dehydrogenase, intracellular citrate levels, inhibits phosphorylkinase, leads to accumulation of intramyocellular glucose 6-phosphate, and ultimately accumulation of intramyocellular glucose and reduced glucose uptake. So what are the principles of therapeutic strategies? We would like to improve insulin signaling, reduce the hepatic glucose output, promote weight loss, and reduce glucotoxicity. This is a wonderful slide which shows how there is a cross-organ talk and what drugs act where. If you look at the first, energy intake and dysbiosis in the adipose tissue, and the drugs that act there, we have dietary medication, bariatric surgery, metformin, GLP-1, and the newer FX3. And the one in yellow are the ones that are in pipeline, the various drugs that are pipeline. Increased free fatty acid leads to white adipose dysfunction and lipolysis. There is a decrease in the adiponectin level, increase in the inflammatory cytokines, the endothelial vesicles, and the drugs acting here are the PPR delta, PPR alpha delta, omega-3 fatty acids, SGLT2, the various anti-inflammatory and the anti-leukins drugs. And then when it goes to the liver, they form lipid toxic intermediates, and this inhibits the insulin signaling cascade, resulting in hepatic insulin resistance and ultimately increase in the endogenous glucose production. And again, the drugs and the treatment is weight loss, the PPRs, the metformin, and the various new drugs like FGF, and there is a special agent KHK which inhibits or increases de novo lipogenesis. And ultimately in the skeletal muscle, there is a decrease in the glucose uptake. So if you look at the site of action of drugs, we have the common drugs like sulfonylurea, GLP-1, and DPP-4, or insulin analogs. Basically, by increasing insulin secretion, they treat hyperglycemia and the pancreatic beta cell failure, and the SGLT2, that basically reduce glucose reabsorption. Now, these are reducing glucotoxicity. They are not true insulin sensitizers, but they act indirectly. But if you look at the liver, skeletal muscle, and adipose tissue, in the liver, it is the gluconeogenesis and metformin, and the newer drugs, the aim is fat oxidation, and the newer drugs in pipeline are the ACC inhibitors, GPAT inhibitors, and the DDAT2 inhibitor. Adipose tissue, classically glitazones, because they're acting on the fat storage. In the skeletal muscle, again, we don't have any specific drug except for the glitazones. And fat, if you're aiming at fat oxidation is the UCP3 activator, and the muscle mass is the myostatin inhibitor. So those in the red are ones that are in pipeline, and those in the other color are the ones we have here. So key strategies of potential future treatment for insulin resistance are targeting an enhancement of beta oxidation in the liver and skeletal muscle and stimulation of muscle quality. Now, let's see how each works. Physical activity increases insulin sensitivity by enhancing muscle mitochondrial biogenetics, GLUT4 protein content and glucose uptake, repartitioning intramyocellular lipids, and reducing fat mass. Then body weight loss by hypercaloric nutrition or metabolic surgery is the most effective strategy to improve the white adipose tissue dysfunction and insulin resistance. And it has been shown now that dietary modification, bariatric surgery, metformin, and the non-steroidal FXRA and the other drugs, they also act via affecting the gut microbiota. Metformin and GLP, we know further secretion of GLP-1, and this mediates satiety and body weight loss. Then there are several pharmacological agents, including the PPR family, the interleukins and synthetic omega acids, that reduce markers of systemic inflammation and insulin resistance. There are certain anti-inflammatory drugs like salicylate and antagonists of the interleukin systems that have been tried and found to be useful. GLP-1, we all know, I've told about how it acts. SGLT2, again, it promotes urinary glucose excretion. And number of further pharmacological agents that I was talking about that are in the pipeline, the basic aim is to augment fatty acid oxidation, whereas KHK targets the de novo lipogenesis. Then we have the nicotinamide and the metformin that stimulate the GLUT4 translocation to the plasma membrane. The PPR delta A act on the skeletal muscle by enhancing fatty acid oxidation. And then the newer family, in the family of PPR glitazoles, is the lobeglitazone, and that has recently been licensed. It shows a satisfactory safety profile and ameliorates insulin resistance and hepatic steatosis in patients with MASLD. The mechanism of action of metformin we have learned quite much now. It's acting on the muscle by activation of AMPK and leading to increased glucose uptake. It's acting in the liver, again activation of AMPK, decreases the ACC activity, decreases gluconeogenesis, gene expression, increased fatty oxide, and decreased fatty liver and hepatic insulin sensitivity. But the true sensitizer is the pioglitazone. It's a PPR gamma, improves insulin sensitivity. On the muscle, it increases glucose uptake and increases GLUT4 expression. In the adipose tissues, decreases lipolysis, increases adiponectin, and liver, it decreases glucose production, decreases hepatic lipid accumulation, and there are a number of cardiometabolic effects like decreasing blood sugar, free fatty acids, inflammation, and cardiovascular risk. So there is basically a shift of fat from the visceral to the subcutaneous adipose tissue, and there is increase in the adiponectin level. So they enhance insulin-mediated glucose uptake, and we have sufficient evidence from various trials. I'm not going to go into details, the benefits of glitazones. The pleiotropic effects of pioglitazone I've already talked about, and besides improving insulin resistance, both peripheral and hepatic, it decreases the size, insulin visceral fat cells also, improves satiety, decreases free fatty acids, interleukins, and in the muscle also it acts. Now, just to compare between metformin and pioglitazone, we all know how they act, but basically the main site of action of metformin is in the liver, whereas that pioglitazone acts in the adipose tissue, muscle, and liver. We all know that pioglitazone causes weight gain, etc. There has to be a judicious selection of patients, pharmacovigilance, and all that. But the bottom line is that metformin is foundational first-line insulin sensitizer for hepatic insulin resistance, where pioglitazone is often the more powerful true peripheral insulin sensitizers, particularly useful when the dominant problem is marked insulin resistance, lipotoxicity, fatty liver, and adipose dysfunction. So if you were to ask me which is the only or the best insulin sensitizer, it is pioglitazone. These are the newer ones that are coming, as I said, the ACC1, ACC2, DJ2 inhibitors, the PPR delta, They're all in phase 1 to phase 2 trials, and we expect that they're going to act on the free fatty acid oxidation and on the myostatin, on the mitochondrial dysfunction. And these are the future therapies. We have the dual and triple incretin agonists, the FGF21 analogs, AMPK activators, microbiome targeted therapies, SIT1 modulators, anti-inflammatory metabolic drugs. Salicylate was initially tried, and the non-steroidal farneside X and the other also improve insulin sensitivity and affect the gut microbiota. So to conclude, insulin resistance is central to metabolic disease. There are multiple pharmacological pathways that now target insulin resistance. Metformin and glitazone, that is pioglitazone, remains the classical insulin sensitizer, pio scoring over metformin. There are others like GLP-1, SGLT2. They basically reduce the glucotoxicity and lipotoxicity, and they can be taken as insulin, modern insulin sensitizers, and they give cardiorenal protection. The future therapies are going to target multi-hormonal metabolic pathways, especially free fatty acid oxidation. Thank you for a patient hearing.
Thank you for informative talk, sir. The forum is open for discussion. Any questions? Any question? Sir, role of monoclonal antibodies in severe insulin resistance.
That is basically against the interleukins. Basically against interleukins.
Rituximab is under trial, even in severe insulin resistance.
But they are again in phase 2, phase 1 trials.
Helps in insulin resistance B syndrome, usually, which is autoimmune.
Sir, very nice talk. So what will be the insulin resistance? You talk about the pioglitazone, and one of the marker of the insulin resistance is the increased BMI or abdominal obesity. All these are there. But in common practice, I'm just asking for the general people, they try to avoid pioglitazone when there is obese people, because some say that there is a weight gain is there. So what is your take on that?
See, weight gain is not seen in all the patients. If I have used pioglitazone, in fact, I use in almost all my patients with diabetes and insulin resistance. And I see weight gain hardly in about 4 to 5% cases. If the weight gain is too much, you stop it. You can't help it. But intensify lifestyle modification, give drugs that are going to make him lose weight, like maybe SGLT2 and add GLP-1 RS. But the amount of benefit that you get from pioglitazone and the dose that we are using today, 15 milligram, does not cause that much problems as such.
Sure. I agree to that. Thank you so much.
Yes, sir. That is a story that has been settled. All the dust has settled, and I think there is no cause at all, because just giving, if you look at the evolution of any cancer or malignancy, it takes years and years and mutation of genes. Just giving pioglitazone for a couple of months cannot lead to malignancy. It is not possible. So, and it has that controversy is now totally settled. There is no causal relationship between pioglitazone and bladder cancer. You can't prove it. That's what I'm saying.
Thank you, sir. We now close the session as we are running late.
Thank you so much, doctors. Thank you to the speaker and chairpersons. We request you to move to the selfie area.